My name is Singh.
And I'm Ahija.
Mariska. My name is Cameron.
Hello, I'm Isabella.
So today we're talking about schistosoma and basically how we're going to resolve this in terms of Senegal people. Now, this disease affects 2.2 million people worldwide, and it's ranked second after malaria, so it definitely requires a look. Now, we were tasked to given $3 million and saying, do you have a solution for this in the Ghana region? Now, we basically came up with a solution, and our first solution was summarized in 2 words: it's empowering community. That is that we listen to them, we work with them, and then we develop a plan with them, and then we implement the plan. Our goal is to be advisor to them. We don't want to be like, we're going to do everything for you. So let's get a little bit more on the objective sides of it. All right. So first, I'm going to read out the project goal for us, which is summarized in 1 sentence, which is to treat existing and prevent future cases of schistosoma through mass medication, community education, and improved water infrastructure. Now, what you'll see here is that we have 4 objectives. I want to break these objectives down for you guys. Is that the first 2 objectives are like what I call direct and acute objectives, which is that we're trying to get to the problem directly because people are getting infected as we're talking right here, and they're getting neurodeficiency. So that's through community education, which is that we're trying to educate them on the behaviors which lead to schistosoma. And then we're giving them mass medication, which is basically we're trying to get to the 40% of total population and dealing with the problem. But that won't solve the problem. That'll just put them in the cycle of education and basically going back with the medication. So the next objective, what I call them, is chronic or long-term. We'll deal with that. That is that providing them with clean water, providing them with the source that will eradicate the snails out of the water and have the balance of plants and snails. And that will take some time, but meanwhile, we do have the short-term plan in there. Next slide, please. Now over here, I have a geographical visualization of what we're going to be doing. Now we were given Senegal and the region of Dangana. I want to get more specific with the locations. That is Rose Bathio, Roseau, Richard Toll, and Dangana. They're shown on the map over here. I know it's a little bit harder to see, but I'm sorry about that. And basically these locations, combined population is 107,000 approximately, which is about a little bit more than our 40% goal that we have. And that was measured in 2013, but that's the most reliable information that I have. And it's obviously more up than that. Now, these locations were chosen because we have this idea of a mobile clinic. So mobile clinic has wheels and needs gas. So all these locations are connected via N2 highway. And they all have gas stations. Now, 2 of these locations don't have medical center and 2 of them do have medical center. That is, we want to see if our mobile clinic is actually the one that's having the effect. Now, other things that we're going to talk about is educational and religious. That will be talked about in community education. Why does that matter? But other things I would need to know is that language, we will have to talk to volunteers who are willing to translate for us, and organizations like Translate Without Borders who are willing to work with us. Then currency, $3 million is different currency in Senegal. So we got to look at financial advisors and see what's the best way to transfer currency because it goes up and down throughout the year. And the other source of income. We don't want to take away from their income. We want to add to the income. So that is something that we have to consider. The other things that I think really matter is the ethnic and religious group, is that we're dealing with a lot of Muslims there. So we got to keep the gender roles and making sure that we got to accommodate for their needs. Other things is poverty and politics. We don't want to create a system where people just get exploited and corrupted. We want to actually have a system that works. And energy is basically, the dam provides energy for a lot of people. So I don't want to be like, hey, let's get rid of a dam. Like that's something that's not possible. So over to Cameron.
Okay, so one of the major reasons schizomyosis is so prevalent in Senegal is due to the lack of health literacy in these communities. We recognize this and think it's crucial to attack the issue by creating education programs for schools, local communities, and religious centers. The teachers and religious leaders would take part in organizing these programs, like playground games, a schizomyosis song, infographics, education tools, storybooks, Blackboard teaching lessons, and gameplay that teachers can teach about parasite life cycle. We can have a poster showing green and red, do this, don't do this. And a lot of this problem is preventable with just hygiene education. We need to teach basic hygiene like hand washing and brushing teeth, but also about prevention and signs and symptoms. We want to educate the local volunteers who can represent the community to teach their fellow community members to make sure that we recognize the cultural boundaries and cultural aspects to make sure that the teaching is applicable to all. There will be a pamphlet to give out at the mobile clinics, and volunteers there can teach about prevention, treatment, and signs and symptoms. So our goal is to have the community have an understanding of disease transmission and prevention, preventing washing dishes in disinfected water, hand hygiene, and teach about transmission through feces. So here there's a sketch of a person either urinating or passing a bowel movement and contaminating the water. And then we watch the cycle of the parasite through the snail in the water, and then we can see the person get infected through the skin. And this is something that we would show to the community.
Can you switch the slide? All right, so the next portion of our plan, includes a two-pronged approach for disease treatment. The first idea is mass drug administration in schools, and then for those who don't attend school, we've decided to implement our mobile clinics. Starting with mass drug administration, the WHO guidelines are once a year for high prevalence areas like northwestern Senegal. Therefore, we're going to conduct 5 mass drug administrations within the 5 years of our plan. We believe that conducting these mass drug administrations in late May or early June is the best time of the year because according to a study done in Dakar, 73% baseline transmission was reduced to 5% after, baseline prevalence was reduced to 5% after a single dose. And then transmission reinfection rates were 13% 2 to 3 months later. So we went from a baseline of 73% to a reinfection rate of 13% after 2 to 3 months. And we feel that if we conduct the mass drug administration in the beginning of June, then that can last through the highest rates of transmission, the summer months when the temperatures are highest. Additionally, for our patients who are not in school, we wanted to introduce mobile clinics, especially because, as we mentioned earlier, not all of the communities that we selected even have local hospitals. So we'll have 4 mobile clinics per community for a total of 16 accounted for in our budget. And these will have basic health and sanitation, as well as additional doses of praziquantel and testing strips so that we can test for schistosomiasis. We believe that these will serve as places of care, especially for women who are not always included in terms of community leader meetings, community leader events. And that way we can target a group of the population that is often at very high risk of infection due to the domestic tasks that they perform very often in the water. We also want to include childcare areas within these mobile clinics so that women can receive care without having to worry about taking care of their children, which we found was a huge barrier to access in terms of them receiving the care that they need. And those childcare areas will also serve as community educational areas, as we mentioned earlier, using some of our educational materials.
So in order to address the disease at its source, we propose a comprehensive strategy to manage the snail population that carries the schistosomiasis. So schistosomiasis sustains disease transmission in a cyclical fashion, and disrupting the cycle can promote community health. So our first objective over here is a biological approach, and we try to follow Padraig Crevet's model, which reintroduces the indigenous freshwater prawns in the Dakar region, which should reduce the infections as these prawns are the natural predators of the schistosome-carrying snails. So our next approach is a chemical perspective. So the gold standard for molluscide treatment in potable water reservoirs is called Babelucide, and it has been tested by the U.S. Fish and Wildlife Services for its high effectiveness and minimal human toxicity. However, more research is necessary to assess its ecological impact in the river system of the Dagana region specifically, as we don't know how the Dagana region has a different ecosystem than what is seen in the United States, as the Baylor has been primarily tested in the Colorado and New Jersey river regions. Lastly, as the Diama Dam caused huge pH and salinity changes in the water in the area, and installation of an aerator system at the dam and the 4 specified locations can help restore water quality to pre-dam conditions, rendering the environment unsuitable for snails while preserving the prawn habitat. So an aerator system enhances oxygenation and water circulation, which is connected to the proliferation and survival of snails and schistosomiasis. Periodic evaluation of water quality in progress is essential to confirm the effectiveness of these procedures in treating the water and reestablishing ecological harmony.
Okay, so the next slide is water infrastructure. We consider climate change adaptation efforts that integrate not only urban but also rural, focusing on mitigating flooding risks and also pollution control and also clean water access by implementing natural water cycle maintenance, water fountains implementation, and water sanitation. The first one will be stormwater management. We target on the urban area because it will be easier to implement and use for large facilities and industries. It also can provide a very cost-effective and natural organic way to save the clean water and also for reducing pollution risks. The next one is water fountain implementation. We focus on the rural area because we believe rural population bear a disproportionate heavy burden on reaching clean water access. So this one will be mitigating this challenge by shortening the travel distance of them to reach out the clean water resources. The water sanitation development is for both urban and rural because it's not only for the public health improvement, but also just directly improve the water quality of the water. Next slide, please. The next one is our Gantt chart. It provides showcase all our objectives in 5 years. As we can see, the first 2 segments, planning and renaissances, we plan to start it within half year. Started to assessment, stakeholder engagement, do the SWOT analysis, and second and third, medication distribution and mobile clinic will be spread throughout the 5 years, continues doing that. Water management and water infrastructure is larger plans, so we plan our step by step, starting to the first year and projected to finish in the year 4 and do a future assessment in the year 5. Next slide, please. So here's our budget. We almost used 3 million and left about 2% of the funding unallocated. And we heavily focused on mobile clinics and water infrastructure and water source treatment because it's more downstream factors. And we are not only rely on 3 million, but also try to reach out to local, national, and international communities for future collaboration and future financial support. Next slide, please.
So some weaknesses that we see could happen with our plan are the unprecedented water treatment strategy, reliance on volunteers, and the selection of community based on accessibility. And some threats that we see are frequent reinfection, rising temperatures, and then the agriculture based economy.
However, we believe that some strengths of our program are that it has both upstream and downstream components, a sustainable workforce, and that it reasonably targets a relatively large portion of the population. And we believe that some opportunities we're very excited about with our plan are connecting with local hospitals and the communities of ours that do have them, as well as expansion to nearby communities that might not have highway or gas access based on how we do in our initial communities, as well as further health education than just schistosomiasis transmission.
So we just want to briefly talk about technology that will be implemented over there. That is that app, which allows you for a learning center, profiles, and like volunteer management, and basically allow international volunteers if we want to incorporate in that, and allow doctors to basically say last dosage up to dosage and track everything. Now, next slide, please. And that will conclude our presentation. We want to thank everybody who did this.